Welcome back to The Deep Dive, the show engineered to give you the ultimate shortcut to being well-informed. We take the most demanding, dense source material, the time that takes weeks of reading and synthesis, and we distill it into critical, actionable knowledge. Our deep dive today is highly specialized and intensely critical. We're focusing on a single high-stakes moment in complex gastrointestinal surgery.
The pancreatic jejunostomy.
This really is the ultimate test of a surgeon's technical mastery, especially in HPB, that's hepatopancreaticobiliary surgery. The PJ, this critical connection that you make between the pancreas and the small bowel after something like a Whipple procedure, well, it's unforgiving.
Unforgiving how?
Its failure leads directly to the dreaded postoperative pancreatic fistula, and that just dramatically increases morbidity, mortality, everything. So our mission today is to extract let's say, the authoritative technical roadmap for success, and we're getting it directly from a surgical notebook crafted for practitioners. Right. And this source material is not theoretical at all. We're drawing from a really comprehensive, structured surgical notebook script. It's specifically designed to provide, and I'm quoting here, clean, structured, exam-safe, OT-safe knowledge. It's for postgraduate trainees, but also for practicing surgeons.
Exactly.
So we're here to synthesize those authoritative technical details, the risk mitigation strategies, and the pivotal decision-making process you need to execute a safe PJ.
And this specific body of work carries some significant institutional and, real-world experiential weight. The editor and primary narrator of this material is Dr. Senthil Kumaran. He's an associate professor of surgery at AIIMS Nagpur in India.
Okay.
His foundation is formidable. We're talking MBBS from JIPMER and MS in general surgery from PGI Chandigarh. These are institutions that are just renowned for high-volume, complex surgical training.
So that's a pedigree that's really built in the operating theater, not just sitting in a library.
Precisely. And his insights are derived from over 15 years of post-MS surgical experience. And crucially, his operative exposure during his residency at PGI Chandigarh, this was under Professor Liswar Kaman and his colleagues, it involved assisting and performing a very, very large volume of these complex pancreatic surgeries.
Wow.
So that gives you a deep foundational understanding of all the technical nuance.
And how is that experience being applied now, where he is today?
Well, currently, his practice at AIIMS Nagpur in India involves a very standardized institutional operative approach. They often use an initial laparoscopic dissection, which allows for, minimally invasive staging and mobilization. And then that's followed by an open reconstruction. This staged approach, which is frequently performed under the guidance of Professor Bhupendra Mehra and his colleagues, it really emphasizes direct hands-on participation and a track record of consistently good patient outcomes.
Which lends immense credibility to the granular technical principles we're about to explore.
It does.
Okay, let's unpack this, starting with the absolute foundation. Before a single stitch is even placed, the surgeon has to understand the anatomy and, crucially, the texture of the material they're working with.
Absolutely. A safe and successful PJ is fundamentally dependent on rapidly and accurately assessing three key factors.
Three things, okay.
The dimensions of the duct, the quality of the parenchymal texture, and the viability of the vascular supply. If you misjudge any one of those, even the best technique in the world will fail.
Let's start with the dimensions then, the pancreatic ductal anatomy. We're talking about the main the duct of Wirsung, right?
That's the one.
So what's the critical measurement threshold here, and why does it matter so much to the choice of how you're going to connect it?
Okay, so the duct of Wirsung runs centrally, or maybe a little postero-superiorly, within the pancreatic scump that's left behind. And the size matters because it dictates feasibility. It dictates what's even possible. A normal non-obstructed duct is small. It's often thin-walled, and it typically measures just 1 to 3 millimeters in diameter.
That's tiny. A fragile, demanding target.
Incredibly. Now, the ideal scenario for the surgeon.
Which is kind of ironic, isn't it? The ideal scenario comes from pathology.
It is. The ideal is a dilated duct. We're talking greater than 3 to 4 millimeters. And this dilation is usually a sign of chronic obstruction, maybe from the tumor itself or from chronic pancreatitis.
So that upstream pressure has changed the anatomy.
Exactly. And functionally, the dilated duct is better because it offers a thicker, more fibrotic wall. And that wall holds sutures beautifully.
So it's a clear, unambiguous target for those critical duct mucosa sutures.
That's it. So yeah, dilation, which is a sign of underlying pathology, is actually a welcome sight in the operating theater, at least from a reconstructed standpoint.
It just completely shifts the risk profile.
It does. If the duct is dilated, the technical difficulty just drops significantly. And, we should also note the accessory duct of Santorini. It's there in many patients, but it's smaller, its drainage pattern is different, so it's generally considered insignificant for the PJ anastomosis itself.
So the focus is Versum.
All on Versum. And the critical takeaway, the thing that frames this entire discussion, is that your final choice of PJ technique, whether it's duct to mucosa versus vagination, that choice is determined by the combination of duct size and gland texture.
You can't separate those two factors.
You cannot divorce them.
Which brings us directly to the texture, the pancreatic parenchyma.
Yeah.
You said this is where the risk of fistula truly lives.
It is.
So walk us through the two operative texture categories and the dangers that come with each.
We basically categorize the texture into two groups, soft and firm. The soft pancreas is, it's the high-risk nightmare scenario.
Okay.
You typically see it in patients who are having a Whipple for, say, a periampullary carcinoma or a distal cholangiocarcinoma.
Yeah.
These are conditions that don't cause chronic inflammation or fibrosis in the gland itself.
And the problem with softness is it just mechanical failure? Is that what it is?
Precisely. The tissue is soft, it's glandular, it's friable. It just does not hold tensile forces well at all. When you try to place sutures, even really fine ones, the tissue tends to lacerate or slip or just pull through. It's a phenomenon we call cheese wiring.
I can picture that.
And that high degree of friability translates into one single, overwhelming risk: pancreatic fistula. The surgical foundation you're trying to build on is just completely unreliable.
So if the soft pancreas is like trying to suture soft cheese, then the firm pancreas must offer, much better mechanical integrity.
That's a perfect analogy. The firm pancreas is characterized by significant fibrosis and inflammation. This is the hallmark of chronic pancreatitis, or, paradoxically, an advanced pancreatic adenocarcinoma, where the tumor has induced this severe desmoplastic or fibrotic reaction.
And that fibrous scaffolding means the tissue holds sutures better.
Much better. While a leak is always possible, the surgeon has a structural foundation that can actually bear the mechanical load you need for a secure connection. The operative feel is, it's a completely different world. The tissue is tough and resilient.
This sounds like it's more of a spectrum than a binary choice. How does a surgeon actually gauge the texture before the operation? Or is it purely an intraoperative, hands-on assessment?
It is predominantly an intraoperative assessment. It's a tactile decision you make right when the pancreatic neck is divided. But, we often anticipate it.
How so?
Well, if the patient has a long history of chronic pancreatitis, or if the imaging shows significant calcification and atrophy, those are signs of fibrosis. Then we expect a firm gland. On the other hand, a patient with a small ampullary lesion and a healthy, plump-looking pancreas on the CT scan, that patient is highly likely to present with a soft stump, and the whole surgical team will prepare for a high-risk anastomosis.
Okay, so that leads to the third critical point, the vascular anatomy, what this source material calls the ischemia trap. We're talking about blood supply to the very taint of the remnant, right?
Yes, and this is a subtle but absolutely lethal vulnerability. The pancreatic stump's blood supply is derived from these fine, often delicate branches of the splenic artery running along the top and the pancreaticoduodenal arcades along the bottom. When the pancreas is divided, the final few millimeters of the tissue, the margins of your anastomosis, they rely on this dense, fine microcirculation network.
And why is that network so easily compromised during the preparation phase?
Because surgeons, quite rightly, have to achieve a clear margin around the tumor and control any bleeding. However, the source explicitly issues a warning against two specific actions: excessive cautery and aggressive skeletonization of the stump.
Okay, let's break this down. Cautery.
Cautery, while it stops bleeding, causes thermal damage and coagulative necrosis. It just fries the fine vessels.
And skeletonization.
Skeletonization, that's stripping the tissue away from the capsule, can interrupt the very last remaining collateral vessels supplying the face of the stump.
What's the direct consequence if that happens, if you damage that microsupply?
The consequence is immediate tissue death or non-viability. The surgical principle is absolute. Ischemia directly equals fistula risk.
A non-perfused stump can't heal.
It can't heal. It becomes necrotic, the sutures pull through the dead tissue, and the seal breaks. And that leads to a massive leakage. Therefore, stump preparation has to be precise, gentle, and minimize any thermal or mechanical trauma. We prioritize viability over absolute hemostasis right at the cut edge.
That structural and physiological understanding really sets the stage for the evolution of the technique itself. I mean, if the pancreas is so fragile and so corrosive, it makes sense that the early attempts were often, well, failures.
Indeed. The historical context is really crucial for appreciating modern techniques. In the early era, before surgeons fully understood the need for precise ductal control, they tried these crude invagination techniques. They'd simply bury the pancreas into the jejunum and hope the intestinal wall would contain the juice.
And what was the outcome of that approach? I can't imagine it was good.
Predictably high failure rates. The pressurized caustic pancreatic juice would just erode its way out of the invagination, and that resulted in high rates of fistula formation and, associated high mortality.
So when did things start to change?
It wasn't until the refinement phase that surgeons recognized two non-negotiable necessities. First, the absolute requirement for guaranteed low-resistance ductal drainage. And second, the pivotal role of creating a dedicated, watertight ductal mucosa anastomosis.
So you needed a specific pipe for the juice, not just a tissue plug.
Exactly. And this recognition leads us to the modern era, where techniques like ductal mucosa, invagination PJ, and the Blumgart modification all exist at the same time. The focus shifted, as you noted, from seeking the one best method to risk customization.
Right.
The key insight that really defines modern pancreatic surgery is that no single PJ is superior in all cases. Selection matters. We learned that the ideal technique for a patient with a firm, dilated duct, say, in chronic pancreatitis, is fundamentally flawed for a patient with a soft, tiny duct. The focus became risk mitigation, customizing the reconstruction to match the inherent risks presented by that specific patient's anatomy and tissue quality.
Understanding when to choose which technique is truly the central decision in the operating theater, minimizing the risk of POPF. Let's just ground this for a second. We know the Y leak prevention, but can you quickly review the indications for PJ, the when we do this?
Sure. The PJ is mandatory whenever the pancreatic parenchyma is transected, and the remaining stump has to be drained safely into the GI tract. So the classic indication is the pancreatic duodenectomy, or the Whipple procedure, where you remove the head of the pancreas, and the remaining body and tail have to be connected to the jejunum.
Right.
It's also required in a central pancreatectomy, where you only take out a middle segment. That actually requires two anastomoses, one to the proximal stump and one to the distal.
And trauma cases, you mentioned.
Less commonly, yes. It's necessary in specific trauma cases that involve pancreatic transection, where just closing it up isn't feasible. In essence, anytime you cut the pancreas, you have to reconstruct the flow.
Okay, now let's detail the three primary techniques outlined in the source, starting with the one that is the anatomical ideal, ductal mucosa.
Right, the ductal mucosa pancreatic osteogenostomy. The principle here is precision. You're creating a direct end-to-side suture line connecting the main pancreatic duct, Wirsung, to a matching little opening you create in the jejunal mucosa.
And this is the most physiological approach.
It is, because it ensures the juice flows directly into the gut lumen without really interacting with the cut parenchymal surface.
So what are the non-negotiable indications that allow a surgeon to even choose this technique? What has to be there?
This technique requires favorable conditions because it is technically the most demanding. The conditions are a dilated duct, ideally greater than 3 to 4 millimeters.
Okay.
A firm, fibrotic pancreas that's capable of holding the supporting sutures.
Right, the texture.
And crucially, the clear, unambiguous identification of the duct. If all those factors align, the advantages are compelling. You get physiological drainage, lower pressure at the anastomosis, and a vastly lower long-term stricture risk.
Why lower stricture risk?
Because the duct isn't being compressed or obscured by a bunch of extra parenchyma. It's a clean connection.
But if the duct is small or the pancreas is soft, trying to do that delicate ductal mucosa suture line is, well, it's fraught with peril. And that leads us to the compromise, invagination.
The invagination, or dunking, pancreatic osteogenostomy. This is the classic technique that's reserved for the high-risk stump. So instead of relying on a tiny, precise mucosal seal, the principle here relies on bulk. The entire pancreatic stump is brought deep into the jejunal lumen, and it's sealed by anchoring the outer pancreatic capsule to the jejunal seromuscular layer.
So you're basically using the bulk of the jejunum as a supportive collar to seal off the leaking pancreas.
That's a great way to put it.
And what are the specific indications that would dictate this choice?
This is the choice for the classic high-risk factors. A small duct, maybe only 1 or 2 millimeters, where precise suturing is almost impossible.
Okay.
A soft pancreas that just won't hold duct sutures. Or When you have difficult duct identification, maybe due to bleeding or poor exposure,
Yeah.
that makes the precise alignment too dangerous or time-consuming.
But this introduces some structural compromises, right? Specifically the risk of ischemia, which we talked about earlier.
That is the trade-off. The act of invagination pushing and securing the entire stump inside the jejunal wall can lead to localized edema and compression of that fragile microcirculation at the stump margin.
So there's your risk of ischemia.
There it is. And furthermore, because the juice is draining into the jejunum through a less controlled opening, you get a less controlled drainage pattern. And there's a theoretical higher risk of long-term ductal obstruction or kinking.
So you're trading long-term patency for immediate security.
You are. The invagination acts as a high-pressure seal. You're trading long-term patency for immediate mechanical security.
Which leaves us with the technique that tries to combine the best of both worlds, the Blumgart modification.
The Blumgart pancreaticogynecostomy. This modification, which was classically advocated by Professor Pierre Blumgart, is a hybrid technique. It's designed specifically to address the instability of that soft, small duct pancreas while still preserving the physiological drainage of a ductal mucosa anastomosis.
So how does it manage that? How does it fuse the precision and the support?
It involves two crucial steps. The first, the inner layer, is the attempt to perform the standard ductal mucosa anastomosis. That provides the inner precise seal for controlled drainage.
And the second step is what makes it a Blumgart.
Yes. The second and defining step is the use of these large, external, anchoring transpancreatic U-sutures. These are placed through the jejunal wall, pass through the entire thickness of the pancreatic stump several millimeters from the cut edge, and then they're brought back out through the jejunal wall and tied on the outside.
That sounds like a really powerful way to secure the pancreas to the jejunum. If it provides such superior mechanical stability, why isn't the Blumgart the universal standard?
That's a critical question, and it really speaks to surgical trade-offs. While the Blumgart offers vastly improved stump fixation and reduced tension, and it has shown reduced fistula rates in a lot of single-center series, especially for soft glands, it comes with costs.
Like what?
First, it is significantly more time-consuming than a simple invagination. Second, and more controversially, it involves passing sutures, usually large, 2 or 3 of material, through the entire thickness of the fragile pancreatic parenchyma.
And that could cause damage.
Well, while it's designed not to compress the duct, some surgeons worry about potential trauma or future fibrosis caused by having these multiple foreign bodies passing through the gland. It requires specific training and really precise execution. The ultimate choice often boils down to the surgeon's comfort level, the patient's stability, and that texture-deck-size combination you see right there in the operation.
So, to summarize, the ductal mucosa is ideal when the anatomy is favorable and the surgeon prioritizes long-term patency.
Correct.
The invagination is a quick, reliable mechanical closure when the stump is just too small or too fragile for precise suturing.
Yes.
And the Blumgart is the reinforced, time-intensive option for that tricky middle ground, where you want both precise drainage and mechanical security.
That is the correct synthesis. It's a risk algorithm that's played out in real time.
Here's where it gets really interesting. The devil is in the thread count and the finesse of the touch. We're moving into the highly granular technical details of execution, which separate the good outcome from the catastrophic leak. If the pancreas tears before it forgives, we need to know exactly how to handle it.
We have to discuss the suturing strategy with extreme precision. Every single detail, from the material to the size, has a specific rationale that's linked to minimizing tissue trauma and maximizing the duration of support.
Let's start with the most delicate part, the ductal mucosa sutures.
These sutures must, without exception, be interrupted sutures.
Not a running stitch, why not?
A continuous running stitch creates a purse string effect. If one section tightens, the entire circumference tightens and you risk compressing the duct. Interrupted sutures allow for a localized failure without a catastrophic breakdown of the entire line.
And the material?
The material must be fine, typically 5-0 or 6-0 PDS or Prolene.
Why that specific size, 5-0 or 6-0? And what is PDS?
We use 6-0 because it's incredibly fine. It's thinner than a typical human hair. This minimal caliper is essential to make sure we don't cause microlacerations or excessive tissue trauma in the delicate ductal mucosa.
Because the duct wall is that fragile.
It is. If we use a coarser suture like 4-0, the chance of cheese wiring through the duct wall increases exponentially. And we choose PDS, which is polydioxanone, because it's a synthetic, slowly absorbable monofilament. It maintains its tensile strength for about 3 to 6 weeks, long enough for the anastomosis to gain its own strength, and then it gradually dissolves.
So it's not permanent.
Right. Prolene is also used if a permanent suture is desired, but PDS is often favored for that controlled absorption profile.
And the goal of that inner layer is hyper-precision. It's all about precise mucosal alignment.
Absolutely. The pancreatic ductal epithelium must be directly opposed to the jejunal mucosa. If the suture incorporates too much submucosal tissue, or if it misses the ductal edge entirely, the pancreatic juice is left to seep into the supporting parenchymal tissue.
And that's a disaster.
It's where it will activate enzymes, cause inflammation, and guarantee a leak. It has to be an epithelial-to-epithelial seal.
Okay, moving outward, we need the structural support from the parenchymal sutures, the outer layer.
These sutures, which provide the bulk mechanical fixation, are generally coarser. We're talking 3-0 or 4-0 PDS. They don't need the hyperfineness of the duct sutures, but they must provide lasting support. The critical technical instruction here is to take minimal bites of the pancreatic tissue.
Minimal bites, so you're not trying to swallow large chunks of pancreas with the needle.
No. This is where we prevent cheese wiring in the larger sense. If the tissue is soft, large bites will just tear right through.
Right.
You need just enough purchase in the supportive stroma to hold the stump face against the jejunal serosa. If you take deep, aggressive, high-tension bites in a soft gland, the suture will just lacerate the parenchyma, creating channels for the juice to escape and failing to provide any mechanical stability.
So you have to handle the needle with respect.
With absolute respect. Avoid crush injury, ensure the track is smooth.
Okay, let's talk about the final act here. Knot placement and tying technique. In most surgery, we teach trainees to tie a secure, firm knot. But here, you're preaching restraint. Why?
Because the goal is apposition, not strangulation. And that is a subtle but absolutely vital distinction. For the ductal mucosa knots, the mandate is absolute. They must be tied extraluminally.
Meaning the knot is outside the jejunal lumen, and the critical instruction is to avoid knots inside the duct lumen. What's the long-term consequence if you place a knot internally?
Well, if you leave non-absorbable suture material, or even a tag of absorbable material, inside that narrow pancreatic duct lumen, it acts as a foreign body. Over time, that suture material can become a nidus for calcium precipitation, and that leads to the formation of pancreatic epiphysis, or stones within the duct.
Which can cause all sorts of problems down the line.
Chronic pancreatitis, pain, future stricture, it negates the entire benefit of the original operation. We tie it just enough to oppose the mucosa and then cut the tag short on the outside.
Now, the external parenchymal sutures, they must be tied gently. The phrase you used earlier really encapsulates the whole surgical philosophy.
Yes, they must be tied gently. The objective is simply apposition, bringing in the surfaces together, not compression. Over-tightening causes ischemia. If a surgeon cinches down aggressively on that soft pancreatic tissue, they are mechanically compressing the fragile capillaries and arterioles that supply the stump.
Which leads to focal tissue necrosis,
Yeah.
the precursor to a fistula.
Exactly. And this demanding level of restraint is summarized by that quote from the source material, which should really echo in every operative theater. Pancreas tears before it forgives. It just demands meticulous handling.
We need to spend a moment on the structural difference between these types of anastomosis. You clarified the single versus double layer concept earlier, using the phrase two components, not two true layers, for the duct mucosa PJ. Help us fully understand that distinction.
In classical GI surgery, a double layer means two circumferentially complete, separate suture lines, usually mucosal and seromuscular. In the duct mucosa PJ, that definition doesn't fully apply. Think of it more as one precise inner seal and then a supportive outer scaffolding.
Okay, walk us through the two functional components again.
Component one is the essential work, that meticulous interrupted duct to jejunal mucosa seam. That's your fluid seal. Component two is the required mechanical support. Interrupted sutures placed between the external pancreatic parenchyma and the seromuscular layer of the jejunum.
So they're not creating a second watertight layer.
No, but they stabilize the entire stump and they shield that delicate intermucosal seal from any external shear or tension forces. It's a mechanical buttress necessary for healing.
Conversely, the invagination PJ is structurally much simpler.
It is. The invagination PJ is, functionally, a single anastomosis. It relies purely on that bulk seromuscular fixation. The surgeon places sutures through the jejunum and into the pancreatic capsule, pulling the entirety of the stump inside. The seal is achieved by the serosal surfaces of the jejunum pressing against the outer capsule of the pancreas, and you're relying on eventual fibrosis and healing to contain the juice.
No specific ductal suture line.
Not at all.
Let's discuss the controversy surrounding the role of pancreatic stents. We see both external draining stents and internal passively placed ones. If they seem to help divert flow, why isn't their use just universal?
The controversy is really rooted in a fundamental lack of universal consensus from large, multi-center randomized controlled trials. Some studies suggest stenting provides no benefit and sometimes even increases infection risk or complicates removal. However, the prevailing pragmatic surgical opinion, which is reflected in this source, is that selective use is mandatory in high-risk situations.
And what defines a high-risk scenario that would necessitate stenting?
The indication list aligns perfectly with the anatomical challenges we've been discussing. A small duct, a particularly soft pancreas,
Okay.
or any instance where the surgeon encountered significant technical difficulty, maybe needing excessive manipulation or difficult suturing. The stent acts as an insurance policy.
And what are the two core mechanisms by which the stent provides that benefit?
First, it maintains duct patency. In the immediate postoperative phase, the anastomosis swells up significantly. A stent acts as a temporary internal scaffolding, ensuring the duct lumen stays open and doesn't kink or compress.
So it allows juice to flow.
And second, it serves to divert that pancreatic juice flow away from the fragile suture line. By preferential flow through the stent, the corrosive juice bypasses the healing tissues, giving the anastomosis time to gain tensile strength before it has to face the full acidic and enzymatic load.
So in the absence of universal trial data, it's that intraoperative assessment of risk that remains the key determinant for selective use.
Exactly. If the surgeon feels uneasy about the tissue quality, the minimal additional time investment for placing a stent is absolutely warranted to mitigate the risk of a catastrophic early failure.
We also need to talk about the physical environment for the anastomosis. The jejunal limb and mesentery, the mantra here is clear. Tension is the enemy.
Tension compromises everything. When you're bringing the jejunum up to the remaining pancreas, and that's often a significant distance, the surgeon has to ensure several things are absolutely guaranteed. There has to be adequate length to ensure zero tension.
Zero tension.
You have to confirm no torsion or twisting of the jejunal limb, which would compromise its blood supply. And you have to confirm that the jejunal tissue has excellent pulsatile vascularity.
If we use an analogy, think of the jejunal limb like a garden hose. If you twist it or stretch it tight, what happens to the pancreatic seal?
What if you twist it? That's torsion. You cut off the water supply, the blood flow to the jejunal wall, making the healing tissue ischemic. If you stretch it tight, that's tension. You physically pull the suture line apart.
And both outcomes violate the core principle.
Tension increases fistula risk. A tension-free, well-perfused jejunal limb isn't just a facilitator of the PJ, it is a critical component of the reconstruction that has to heal reliably.
Before the closure, the source material integrates a crucial concept from checklist surgery: contamination control and stump handling. This addresses the chemical environment.
This step is all about minimizing the inflammatory load and maximizing the viability of the tissue right up until the point you start sewing. First, you have to clearly identify the pancreatic duct and protect it.
Yeah.
Second, and this is critical for tissue viability, is the strict warning to avoid crushing the stump with clamps or heavy instruments during preparation.
What's the alternative?
Many surgeons prefer using gentle stay sutures or softer traction rather than traumatic clamps that can instantly compromise the microcirculation.
And the contamination control, specifically involving the pancreatic juice itself.
Pancreatic juice isn't just fluid. It's an inflammatory agent loaded with enzymes. If it spills, it initiates a localized peritonitis. Therefore, you must suction pancreatic juice immediately if it leaks, and you irrigate the field aggressively if significant spillage occurs.
And there's one last step.
Yes. The source mandates a final, critical procedural pause for contamination control. Change gloves before performing the anastomosis.
Why is that so important?
It prevents the implantation of potentially activated enzymes or contaminating bacteria into the fresh, delicate suture line. It ensures the cleanest possible environment for healing.
That level of granular detail really defines the difference between a textbook explanation and, operative wisdom derived from 15 years of practice.
Once the complex anastomosis is complete, the surgeon performs the final procedural accountability step, the final intraoperative check. This is the non-negotiable mandatory pre-closure review. It's the final moment to spot a fatal technical flaw.
Let's run through the full 6-point checklist that must be verbally confirmed before the abdomen is closed.
Okay. The surgeon has to confirm the viability and integrity of the entire reconstruction chain. Number 1. Duct clearly identified. Did we successfully connect the duct to the mucosa, or did the suture line slip, creating a pseudoanastomosis?
Number 2.
Anastomosis tension-free. Is the jejunal limb lying in a relaxed, natural position without any upward or lateral pull on the pancreas?
Number 3.
Pancreatic stump viable. No ischemia. Does the tissue color look pink and perfused? A gray, cyanotic, or obviously crushed stump has to be re-resected or buttressed.
Number 4.
No bleeding from parenchyma. Is there any active ooze? Even a small contained hematoma can compress the duct, impair local blood flow, and act as a bacterial medium, dramatically increasing infection and leak risk.
Number 5.
No twist in the jejunal limb. Is the reconstruction completely aligned, ensuring good vascularity and drainage for the jejunum itself?
And finally, number 6.
Drain placed appropriately. Is the drain placed near the anastomosis? Close enough for surveillance, but not touching the anastomosis.
That last point about the drain placement is critical. Placing the drain too close or under suction can actually create a fistula by eroding the healing tissue, and this leads directly into the postoperative anticipation phase. The closure of the abdomen marks the beginning of the most dangerous period for the PJ.
Absolutely. The first week post-op is when the anastomosis will either hold or fail. And the single most crucial surveillance tool, the early warning system, is the monitoring of drain amylase. This test has to be performed on postoperative day 3, POD3.
Why is that TOD3 marker so specific?
Postoperative pancreatic fistula, or POPF, is officially defined based on drain fluid amylase levels that are greater than 3 times the upper limit of normal serum amylase, and that's regardless of the clinical status of the patient. If the drain amylase is high on POD3, it means pancreatic juice is finding its way into the drain rather than fully into the jejunum.
So it gives the surgical team a definitive early warning of an anatomical leak.
Yes, often before the patient even shows clinical symptoms like fever or pain or sepsis.
So early detection essentially buys the patient time for more conservative management.
Precisely. If we detect POPF early, we can manage it conservatively by maintaining the drain, controlling infection, ensuring optimal nutritional support while the body tries to seal the leak internally. If detection is delayed, the situation can escalate rapidly into generalized abdominal sepsis, requiring invasive, life-threatening interventions.
Beyond the fistula, what are the other key complications the surgical team is actively watching for in this critical postoperative week?
Well, while POPF is a primary concern related to the PJ, 2 other major complications are closely monitored. The second is delayed gastric emptying, or DGE, which is very common after a Whipple procedure due to all the regional manipulation, nerve disruption, and local inflammation.
That's manageable, though.
It prolongs hospitalization, but it's usually manageable. The third, of course, is intra-abdominal hemorrhage, which has to be addressed immediately. The final urgency note from the source is the true operational reality. Early detection saves lives. In this high-stakes context, that principle guides every single decision, from drain placement to the monitoring schedule.
So what does this all mean? We've navigated the surgical minefield of the pancreaticojejunostomy, covering the entire spectrum from the 1 mm duct to the extraluminal knot. The major takeaway isn't just the mechanics, but the mindset. The decision duct to mucosa versus invagination versus Blumgart is an exercise in customizing risk based entirely on 2 primary intraoperative variables, duct size and gland texture. It requires a deep respect for tissue and a surgeon's total intellectual capacity, not just their manual dexterity.
That synthesis perfectly captures the intellectual core of the source material. We set out to extract the definitive exam-safe, OT-safe knowledge. So before we close, let's condense the mandatory checklists and core principles for immediate recall and memorability.
The ultimate reference points for the learner.
Okay, first, the operative checklist summary. For immediate recall, the mandatory surgical checks before closing the abdomen are: check for clear duct identification. Ensure the anastomosis is tension-free. Verify pancreatic stump viability, no ischemia. Confirm no bleeding from the parenchyma. Check for no twist in the jejunal limb. And confirm appropriate drain placement. That means near, but not touching, the anastomosis. Next, the 1-page take-home summary. If you internalize only 5 concepts from this discussion, let them be these foundational principles. 1. PJ technique selection must be based on the unique combination of duct size plus gland texture. 2. Duct to mucosa is the physiological ideal, preferred when the anatomy allows for it. 3. Soft pancreas instantly signals a high fistula risk, requiring maximum mechanical security, so an invagination or Blumgart. 4. Gentle handling, minimal trauma, and precise suturing are universally superior to simply choosing the fanciest technique. And 5. The operative mantra recap. No tension, no ischemia, no crushing.
And the final mantra.
And the operative mantra that encapsulates the entire technical challenge and the consequence of failure. The pancreas leaks when rushed, strangled, or ignored.
That's powerful. Now, I know there are some key people and institutions you wanted to make sure we credit for this body of work.
Yes. In the acknowledgement segment, I would like to acknowledge and express my deepest gratitude to Mr. Nilesh Lodhaji, a respected teacher, philanthropist, and businessman from Chennai, India, whose guidance and mentorship have been invaluable in developing and compiling these principles, and for the authorship and editorial declaration. This structured technical deep dive was derived from the surgical notebook script compiled and edited by Dr. Senthil Kumaran, Associate Professor of Surgery, AIIMS Nagpur, India. Dr. Kumaran drew extensively on his surgical training from PGMer under Professor Lileshwar Kaman, and the content reflects the current high-volume institutional approach at AIIMS Nagpur, often performed in collaboration with Professor Prapendra Mehra and colleagues.
A truly masterclass synthesis of a highly specialized topic that underscores how much of surgery is intellectual customization before its mechanical execution. This leaves us with one final provocative thought for the learner. Given the intense mechanical fragility of the soft pancreas, the tissue that tears before it forgives, and the ever-present threat of ischemia caused by tight sutures, what evolving non-suture technologies, perhaps highly specific bioadhesives, surgical patches reinforced with fibrin glue, or even external buttressing rings, might be explored in future studies to further mitigate fistula risk in these specific soft pancreas patient populations? The next revolution in PJ might just bypass the needle entirely, building upon those core principles of a tension-free, non-crushing anastomosis.
That ongoing exploration of how chemistry and material science can supplement surgical mechanics is undoubtedly where the cutting edge of pancreatic safety resides.
Thank you for joining us for this deep dive into the surgical principles of pancreatic osteogeneostomy. We'll see you next time.